Hello, I'm Rachel Babin from Oncology News Australia, proud producers of the Oncology Journal Club podcast. In today's special ASCO 2021 episode, Craig Underhill talks to Lisa Horvath and Craig Gedye about all things GU cancer. It's a thorough and entertaining discussion covering practice-changing developments and controversial trials. As ever, you'll find full bios, Twitter handles, and all the links to the papers discussed in the notes on our website. For regular news and podcast updates, subscribe to the Oncology newsletter on oncologynews.com.au. It's free and it's a great way to support the OJC. This is Rachel Babin and this is the Oncology Podcast.
G'day, g'day, g'day. It's a great pleasure to welcome two Aussie guests onto the Oncology Journal podcast, post-ASCO GU special. Firstly, Professor Lisa Horvath from the Chris O'Brien Lifehouse Centre in Sydney, medical oncologist and cancer researcher. Welcome to the podcast for the first time, Lisa.
Thank you. I'm looking forward to it.
Fantastic. And great name, Craig Gedye, Associate Professor Craig Gedye, in fact, from the Mater Hospital in Newcastle. He's the Director of the Hunter Medical Research Centre. Craig, welcome to the podcast.
Thanks so much, Craig. Pleasure to be here.
All right, so let's get into it. There was quite good sessions in genitourinary at ASCO this year, in particular, I think, in prostate. And Lisa will lead us off in the discussion about some of the oral prostate cancer patients. And in fact, Lisa was one of the discussants in that session. So congratulations, Lisa. I'm sure that was amazing to be involved in that process, and I'm sure a lot of work. So it's great to have you on and to share some of those insights on the podcast today.
Oh, thank you, Craig. And yes, it was a great honour to be asked, and they were really interesting abstracts. So I might kick off with talking about the Piece 1 study, because I think that's what's generated the most discussion out of the prostate cancer orals. So just to sort of recap, the Piece 1 study is a 2x2 factorial design randomised phase 3 of men with de novo metastatic hormone-sensitive prostate cancer, and it was looking at both radiotherapy and abiraterone. And this is the first interim analysis that was just looking at the abiraterone arms, because they found no interaction between the abiraterone and radiotherapy, so they were able to combine the abiraterone arms. What got complex but also very interesting was that their standard of care changed across the course of the study. They started off with ADT alone, and then as the various Chartered and Stampede studies came out, they moved from ADT alone to ADT plus docetaxel at the discretion of the investigator to mandatory docetaxel by the last 2 years of recruitment. So they ended up with docetaxel as a stratification variable, but they had the greatest number of patients treated with concurrent docetaxel, ADT and abiraterone that we've seen, very similar to the Enzamet study, but with a higher proportion of those patients. The study has co-primary endpoints of RPFS and overall survival, and they were reporting the RPFS result. The overall RPFS for the whole cohort, not surprisingly, because abiraterone is already routinely being used in hormone-sensitive prostate cancer, was a nice big improvement in radiographic progression-free survival of around 2.5 years. They then looked at the subgroup of patients that had docetaxel and again found an improvement around 2.5 years by adding the abiraterone. And that's actually very similar to what was seen in Enzamet. The hazard ratios are very similar for radiographic progression-free survival. Interestingly, they saw minimal additional toxicity with adding abiraterone to the docetaxel, whereas in Enzamet, adding the enzalutamide to the docetaxel had caused some increase in peripheral neuropathy. But we've only got that sort of 6 months AE data as yet. It's the biggest trial we've yet seen in the triplet environment, but it doesn't have overall survival benefit, whereas Enzamet did have overall survival benefit at 3 years at least and didn't see an improvement in overall survival with the triplet. So it's fascinating data, but it really needs more follow-up. The Enzamet and the PEACE-1 study, combined with the data from ARASENS, which is the other large randomised trial in this space, will be really fascinating as they evolve. ARASENS, of course, is mandatory docetaxel with ADT plus or minus darolutamide. So we'll have 3 big studies to really look at. Another interesting point that was discussed was the change in the standard of care. More than half the patients had high volume disease, and I think we don't have much of an argument that we'd give docetaxel for high volume disease. But what constitutes standard of care for low volume disease? And certainly there's ample data that androgen receptor signaling inhibitors, ABI, Enza, apalutamide, they're all good choices for low volume disease. But there's a lot of controversy about how much you would use docetaxel in the low volume setting. We know Chartered didn't show benefit, Stampede did. And if you look at the consensus conference from 2019, only 20% of delegates said they would put docetaxel in the mix for low volume disease. So it'll be very interesting to see how many of these patients with docetaxel were high volume versus low volume and getting down to the granularity of that study.
So, Lisa, how do you define the low volume disease? And look, we have this discussion every MDT about which of these patients should get docetaxel. So, assuming they're, fit to have it, do you have a rough cutoff in your MDT or in your mind when you use it and don't?
I follow the Chartered definition of greater than or equal to 4 bone mets and or visceral disease. But I think the bigger problem in Australia is that we're, of course, not using conventional imaging anymore. I can't remember the last time somebody turned up to my clinic with a bone scan. Patients are referred with PSMA PET scans, and clearly 5 bone mets on a PSMA PET scan may be 1 or 2 bone mets on conventional imaging. I think a lot of us, myself included, are probably treating based on the PSMA PET scans with the same sort of definitions, but we know these patients are much earlier than the patients with the same definitions on Chartered and Stampede. So it's very tricky in the Australian environment to translate.
It's not everywhere in Australia. So out here in the regions, not every patient has access to a PSMA PET scan. We've got compassionate access for some patients, but some patients can't afford to take them. So we do see a mix, and sometimes we even will arrange for a conventional bone scan as a baseline to understand that patient's burden to help them make that decision. But more importantly, going forwards, we're going to need to actually look at our experience with comparing bone scan and PSMA PET scans to help us answer this question for men moving forwards. The other question I had was, de novo metastatic disease in PEACE-1, which is a really good definition. It's a really robust definition. But of course, who do you offer docetaxel to? Is it the de novos that are more important, or it's the high volume metachronous? So is there a difference, do you think, between those two biologies?
I think that's a really good question, Craig, and I think we don't know enough about the biology yet, and that's the next stage that's coming. I'm a firm believer in what IceCap and StopCap are trying to do, developing risk stratification based on both clinical and biological results. And I think that's really going to help us in that scenario, because I'm a biologist. I'm biased. I believe there's going to be a biology that does better with docetaxel versus an androgen receptor signaling inhibitor. And maybe down the track, if studies like upfront PSMA relevant, maybe a different biology that will allow us to pick who should get lutetium. So I think the biology is essential, and those studies in Chartered and Stampede and now Enzamet are just starting to be done. One of the posters at ASCO was from Gerd Attard and the Stampede group, showing that there are a higher rate of genomic aberrations in patients with de novo disease and those with a shorter radiographic progression-free survival. But that's the tip of the iceberg in terms of what's coming.
Yeah, thanks. I had a couple of other questions. When the chemotherapy was given, when the docetaxel was given in piece 1, was it concurrent or sequential with abiraterone? Was it on top of the abiraterone or before the abiraterone started?
No, it was concurrent, so pretty much the same as the Enzamet study and the ARASEN. So they were all concurrent, unlike Archer's, for instance, where it was sequential.
And we know from breast cancer that you shouldn't combine hormonal agents and chemotherapy. Has that been looked at all in prostate cancer? I'm not aware if anybody's compared concurrent versus sequential treatment in this kind of setting.
Nobody has, although it's interesting that there are a couple of docetaxel adjuvant studies, particularly in the localized setting, where they didn't use ADT and they were not only not effective, they're actually dangerous. So it's interesting, although there's no direct comparison, it certainly does seem that you need the ADT with the docetaxel to get a benefit in prostate cancer, unlike breast cancer. And Howard Gurney's done some interesting data looking at drug handling with docetaxel in CRPC, suggesting that the ADT can actually change the pharmacokinetics of the docetaxel.
So, Lisa, if the androgen receptor inhibitors were available in Australia for the metastatic castrate-sensitive prostate cancer, would you be recommending triple therapy with ADT, docetaxel, and an ARI, or do you think we still need to wait for some more survival data?
I'm conservative in this space, and if anybody's seen the discussion, they'll see that the opinions on that divvied right down the middle on the panel. Two of us thought we should wait for overall survival data, and two were very keen to move ahead with the triplet. I am more conservative. I'd like to see the overall survival data. I'd also like to see the quality of life data. Is this a question of sequencing and granularity around who actually was in that group? Karim Fizazi in the discussion did say that he felt that more of the patients who, once docetaxel became mandatory, were high volume, but none of that was reported. So the subgroup analysis of the overall didn't show any particular benefit for the high versus low volume, but there's more granularity and more information to come. I'm still reluctant to take somebody with 3 bone metastases and give them triplet therapy in this setting.
Okay. And Craig, do you agree you wanting to wait too for some survival data?
Yeah, I think so. This is ever and always the question, do we give early or do we give late? What's the sequence? And in fact, some of the research that Lisa is embarking on and some that I'm looking at as well is, do we actually build in delays? Do we actually think about sequencing the treatment differently to actually extend the duration of the benefit longer? And my final comment or question was really a comment, I guess, is that pragmatically, abiraterone's generic now, and we know that 250 milligrams with food is the same as 1,000 milligrams before breakfast. So if any of these agents is going to get up, this is the one. So, just the sheer economics of it, it's going to lead it to be the agent that we're considering.
Okay, thank you.
I agree. Can I make one other comment that I think just emphasise what Craig said? I think it's the second study, the SWOG study, showed a very long survival, although the drug TAC 700 was negative. And I think what Craig said is incredibly important in terms of using intermittent treatment. Not only can we see if it's better for resistance mechanisms, but is it better quality of life? We're talking about giving ADT to men for 3 to 5 years. And we know from the Latitude study, 20% of them stopped because of toxicity. So intermittent regimens will be really important in randomised trials going forward to see if we can make this better for men.
Fantastic. Okay. And then piece 3, Lisa, sort of highlighted the importance about bone agents. We sometimes sort of forget about that in the discussion and the management. So can you tell us a little bit about the piece 3 study?
So the piece 3 study is actually a study of metastatic castration-resistant disease with patients on enzalutamide randomised to radium-223. And like the ERA-223 study, had noticed an excess of fractures in men on the radium arm. In ERA-223 that Bertram Trumbull had presented last year, I think it was, the Data Safety Monitoring Committee had instituted bone protective agents and shown an improvement in that fracture rate. So the Peace 3 study group, the intervention was really the decision of Independent Data Safety Monitoring Committee to mandate the use of bone protective agents. So this isn't a randomised trial. This is seeing what happened before and after the safety notice. Before the safety notice, around 60% of people were giving the bone protective agents, and this is bone protective agents in a CRPC setting. So this is monthly denosumab and zoledronic acid. So we're not talking about the osteoporotic doses. So what was really interesting was not only did this decrease the risk of fractures in the radium arm, it dramatically decreased the risk of fractures in the enzalutamide arm. And I'm struggling at this hour of the morning to remember the exact percentages, but it was something like 14% down to 2% in the enzalutamide arm with the mandatory bone protection agents. And it really brought out the issue of we're all a bit scared of giving bone protection agents. We've all become gun shy because of osteonecrosis of the jaw. But when you compare around a 5% risk in the CRPC doses of osteonecrosis of the jaw versus dropping the fracture rate from 14 to 2%, that is a significant difference in terms of morbidity. So it really brought out that we should be more proactive in this area. And if you look at some of the real-time data, as oncologists, we are reluctant to commit people to protracted amounts of denosumab or zoledronic acid. There are some other interesting studies in the space. The REDUCE study is looking at monthly versus 3-monthly denosumab, and again, that may show a change in the toxicity profile. It also fed into the conversation around what do we do now that the control group in the SWOG study that was presented between the two PEACE studies was 70 months for overall survival. So given that these patients are going to live for many years, we probably need to be thinking very much about their bones at the beginning of their disease and through the continuum. Again, harking back to that discussion about how do we maintain quality of life and activity for these men who really want to continue living their lives.
Thank you very much. We're going to change track now just to talk about also in the castrate-resistant prostate cancer, but really sort of towards the end of the journey, and that's the VISION study from the plenary. So it was one of the, I guess, more controversial abstracts. Again, Lisa, do you want to lead off on outlining that study?
So the VISION study is a randomised controlled trial of lutetium PSMA against best standard of care, really for men who had all their previous treatment. The key aspect to it was that the primary endpoint of overall survival was met, and they identified a 4-month improvement in overall survival in this group of men, which is pretty much in keeping with what we've seen in most treatments, most randomised controlled trials, whether it was ABI or ENZA or even carbazitaxel. These are the standard sort of improvements in overall survival. For Australians, of course, we had the therapy study, which was lutetium PSMA versus carbazitaxel, which was essentially a third-line treatment, and that was a randomised phase 2, but the primary endpoint was PSA response rather than overall survival. Both of these studies show an improvement in PSA response, improvement in objective response with lutetium, but there was no active control arm in TITAN. Patients were essentially getting bits and pieces of other treatment, but none of them were life-prolonging treatment. The other aspect to the TITAN study was that they had a very different entry criteria with regards to imaging compared to what was used in the therapy study, in which Michael Morris on the Euromigos podcast termed the Hoffman criteria. In Australia, the nuclear medicine physicians have really been looking very closely at the amount of PSMA uptake, whether there's concordance or lack of concordance with FDG disease, and there was around 28% of patients on the therapy study who never made it through to randomisation based on this very strict criteria. The VISION study had a 10% dropout on the basis of the pre-screening imaging. They did PSMA PET scan alone. They did no FDG PET, and they had a much lower criteria in terms of PSMA uptake for patients entering the trial. So some would argue, well, that puts them at a disadvantage, and they still showed an overall survival benefit, and it's a much bigger trial than therapy. But if they'd used a more stringent criteria, this difference may have been a lot higher. I think the really good thing about the VISION trial is when you put therapy and the VISION trial together, hopefully this is now really going to start the ball rolling in terms of getting FDA approval and rolling this through. My fear, however, based on some of the discussions, is that certainly in the US there seems to be a feeling we should just be giving it to everyone. It's a very expensive treatment, and I think we do need to be more stringent in who we're giving it to. It's certainly not going to get through PBAC in Australia if we don't have that sort of criteria, and it's not something that patients can routinely afford.
Yeah. Craig, do you agree with those thoughts?
Yeah, look, so watching social media, you could see some of the cowboys were going, oh yeah, I give it to people if they've got a prostate, or if they knew someone who's got a prostate, or
I know, it's like the new standard of care, and it's like they're all barracking for their mates.
So this is a targeted therapy, and it's a targeted therapy like any other targeted therapy. If the target's there, you're going to get a benefit. If the target's not there, you're not going to get a benefit. And like any other targeted therapy, it'll breed resistance, and you'll start to lose efficacy as you use more and more of it. And I think we're seeing that, So how do we use it? Do we use short doses? Do we split it up? Do we give all 6 doses at once and stop? There's a multitude of questions, and again, being led by people like Michael Hoffman and Louise Emmett here in Australia, we're getting all of those kinds of amazing questions being addressed, and it's just fabulous to be part of that. The therapy study is the saving grace for Vision. So Vision's a marketing nightmare for the companies, same as Profound was for AstraZeneca. Yes, you've got a drug that's active, but you've compared it against a strawman comparator, and you've compared it against therapies that are not necessarily going to work. I mean, you say standard of care, but you're not allowed to use drugs that might actually help the patient. Okay. So therapy rescues Vision because therapy was an active comparator. And again, we've seen editorials on therapy that people congratulated ANZUP on being courageous enough to run a study with the new drug against the active comparator. You shouldn't be courageous; that's ethical. And I personally found therapy a very easy study to recruit to because it was entirely ethical. A man was about to take cabazitaxel. You could give him information, consent about that, and then say, and by the way, there's one more thing. You could potentially take a randomization to take a 50% chance of an extra agent. So ethical studies are easy studies.
And Craig, were you able to deliver the lutetium in Newcastle, or did you have to refer the patients off-site?
So I'd like to shout out to Dr. Natalie Rutherford, who's the Director of Nuclear Medicine here, and to ArtNet, and to Ross Francis from and the ArtNet team, and Louise Emma and Michael Hoffman, who gave us a lot of support to get that set up. It was a new implementation of lutetium here. We were the only non-capital site to participate, and we're the only non-capital site in NZP, for example. So it's been an enormous amount of goodwill and great work to get it set up. But it is possible. It shows that when you get through all the guidance and the governance, that it is possible. So it does have implications for how we can deliver this, not just in capital city centres into the future.
Yeah, I've had discussions with our nuclear medicine department here who do PSMA scans and Gedye PET scans, and they say that if it's reimbursed and with some mentoring, it should not be so complicated to deliver in larger regional centres. So that's reassuring. So let's switch track. I'm just mindful of the time. It's been a great discussion, but let's look at the renal adjuvants. Again, another controversial study. Craig, do you want to outline this paper?
Yeah, so thanks. It's not controversial. It's a perfectly sensible question, and question that we're starting to move forwards in the right way, but the answer's not settled yet.
Yeah, no, I thought that was controversial because, again, on the Twitter sphere, it was like, this isn't now done, this is what we should be doing for patients. But let's quickly go through the Highline data and then talk about that.
So this is the Keynote 564 study. It's a randomized double-blind phase 3 of pembrolizumab versus placebo in people with high-risk resected clear cell renal cell carcinoma. A shout out to Tom Ferguson in Perth, who was one of the lead recruiters for that study. So adjuvant therapy for renal cell cancer, the only study that's ever shown an overall survival advantage was, in fact, an immunotherapy study of an autologous vaccine, 20 or 30 years ago. So we've been waiting with bated breath for immunotherapy trials in this space. The design was fairly typical for all of these immunotherapy adjuvant studies. So patients are combed over very carefully. So they're very highly selected patients who go into the study. And the treatment was Pembro 200 fixed dose 3 weekly for a year. So again, sort of fairly typical. Trying to figure out what risk categories and who's got high-risk renal cell cancer is really hard in these studies. There's been all sorts of classifications. This one, they looked at people with intermediate high risk, either had grade 4 sarcomatoid, or they had T3 tumours, or they had N+ tumours as well, or they had M1 disease that was resected. So a little bit more pragmatic in the classifications, a little bit more understandable, rather than trying to figure out a Leibowitz score. The disposition of the patients in the study was interesting. So a lot of patients in the treatment arm discontinued with adverse events, and exactly equivalent number for the number of patients who discontinued in the placebo arm with disease relapse. So you really are making a trade-off here in terms of toxicity versus the progression event. So the primary endpoint was disease-free survival for the study, and so the first planned interim analysis, they peeked inside using as much of their P as possible to look for that outcome. And of course, it was positive. You've got an obvious difference between disease-free survival at the 12 and 24 months, and the median, or the percentage at the median follow-up at 24 months was 22 versus 30%. So an 8% absolute risk reduction in disease-free survival. So, clearly something there. The interesting thing, though, was there was a difference between Europe and the rest of the world and North America. So it would be very interesting to see if there's different practices in those spaces that have led to that. The interim overall survival, however, if you use the Fran Boyle rule of standing at the back of Hall A, you wandered into the plenary and, you can't find a seat, and the discussant or the presenter puts up the slide and you put your finger up. You've got to be able to get your finger between the two curves on the Kaplan-Meier curve to know that this will get a PBS reimbursement. And so again, at 20, we've got almost exactly 500 in each arm randomized. So if you go down to medium follow-up with about 250 patients at risk in each group, that's at 24 months. And the two curves are largely indistinguishable. You've got an overall survival of 6.6 in the placebo, event rate of 6.6 in the placebo versus 3.6 in the intervention. And then compare that with the toxicity. You've got a 1.5% risk of thyroiditis, or 11 of hypothyroidism, 21% of hypothyroidism, pneumonitis 2%, adrenal insufficiency 2%, type 1 diabetes, which is is nothing more humiliating than giving someone adjuvant immunotherapy and converting them into a type 1 diabetic, 2%. So there's a broad amount of toxicity there. So does immunotherapy work for renal cell cancer? Yes, we knew that. Does anti-PD-1 immunotherapy work for renal cell cancer? Yeah, absolutely. In the metastatic setting now, we've got the constant bun fight and squabble about what should go with the anti-PD-1. Should it be ipilimumab? Should it be the checkpoint? Should it be a tyrosine kinase inhibitor? So no great surprises in any of this. But should this change practice immediately? And the answer is, of course, no, because we can't see a overall survival advantage at this stage. But more broadly, in the other parts of ASCO, there's now an adjuvant PD-L1 inhibitor for some people with lung cancer. And there was a New England Journal article the week before ASCO for the 274 study for bladder cancer. So suddenly our clinics are going to be inundated with people who have clinical evidence for adjuvant immunotherapy after their surgery. So suddenly we're going to need to double the number of oncologists for Australia. That's going to be an interesting conundrum.
Yeah, it certainly didn't stop people on Twitter saying they hadn't been to this Fran Boyle school of trial significance, because they were posting those curves and putting an arrow where they just separated barely at the tail and going, look, this is going to become a positive study. So I think we do need to wait, but let's hope it does become positive, because the disease-free survival was, an 8% benefit. We'd often see much less in things like breast cancer and consider them to be standard. So we'll wait and see.
So again, this is where Australia will take the lead. Once again, the work of Peter Gibbs and Gedye out of the WEHI has shown us that looking for biomarkers of minimal residual disease will help us select patients who should be offered adjuvant therapies in colorectal cancer. And so we've got to join that for all of these other cancers, because we're getting better and better markers of MRD for many cancers. And I think that'll help us to reassure patients that they don't have any evidence of cancer in their body. They shouldn't take an extra treatment. And that'll substantially reduce the burden of these on the healthcare system and on our patients, but also provide ways of getting better value and better risk benefits for patients. So again, I think Australia's got a great opportunity to try and drive those kinds of clinical trials through to prove the benefit of using circulating biomarkers like ctDNA or methylated DNA as ways of predicting who needs adjuvant treatment and who doesn't.
Yeah, good comment. It's a plug for more clinical trials, isn't it? So we're running out of time, but just quickly, Craig, I know you would have been interested in the nivolumab plus cabozantinib in patients with non-clear cell renal cell carcinoma, phase 2 study, which shows this was an active drug, similar to a study we've done in Australia. Did you want to comment on that one?
Yeah. So look, there was a lot of follow-up data in clear cell metastatic studies, some of the big phase 3s, but there were 3 phase 2s. There was our own Unison study. There was a study from Yale with Michael Atkins as the lead, and a study from Memorial with Bob Motzer as the senior author, looking at combinations of agents in people with the rare variant kidney cancers, the non-clear cells. And so we found the same relatively humbling results with checkpoint inhibitors in this population of patients, that there's certainly people that we're helping with either nivolumab alone or nivolumab and ipilimumab. The Memorial phase 2 is a small study. They showed really quite promising activity with the cabo-nivo combination, but what the durability of that will look like is, the next step. I think the sobering and somber thing to reflect on across all of those studies is that patients with chromophobe renal cell cancer, which is usually low risk and often doesn't metastasize, but when it does, nothing seems to touch it. The checkpoints or the TKIs are not seeming to deliver a lot of benefits. So a humbling situation that we need to think about that perhaps it's very rare, but it's a separate disease.
Yeah. And just lastly, we saw a bit of hype in the urothelial cancer space after the ASCO genitourinary meeting earlier in the year. And this meeting, and we'll put the links to the abstracts, but there were 3 studies in locally advanced bladder cancer that were probably not practice changing, but really of interest, with a move towards having combination treatments that may be truly bladder sparing.
Yeah. So it was nicely discussed. There was a European and 2 US studies, and there were various combinations: gem, cis, and nivolumab, durvalumab, tremelimumab, and concurrent radiotherapy, and gem, cis, but essentially opportunities to try and decide if we can actually spare people's bladders, because nothing more debilitating than a cystectomy. And even, we've got lots of experts that look after these patients in Australia, but it's a very big operation. And then the morbidity of carrying a stoma around for the rest of your life. So finding ways of predicting who might benefit from them, and it's still unclear if we can predict upfront who will benefit from these therapies. But again, it may be a situation of trying to select whether it's which chemotherapy or adding immunotherapy or radiation, and then again, better markers of minimal residual disease to understand who is actually being well controlled and has a disease well controlled and can forego an upfront cystectomy. I think none of it's ready for prime time, but it certainly shows us the direction that we're moving towards.
Fantastic. So what's the thing you miss most about going to Chicago, Lisa?
Chatting afterwards and arguing about the results. It's not the same on Zoom. You don't have that same buzz. And I think, like many of us last year, we were living in the COVID fog and you didn't really miss it. By this year, I really missed it.
And Craig, you missed the coffee?
Do I miss the coffee? No.
Call my place coffee.
No one misses the coffee. But look, what I missed is what we've adapted. So I missed the opportunity to meet new people, talk to new people, look to deliver more opportunities for Australians for new clinical trials in GU and other cancers. And there's a lot we did with handshakes and physical body language, But we've learned to adapt. I mean, this podcast is an example. We've embraced different ways of communicating, and in fact, I've been excited this year to be starting collaborations with people I've never met before, that I've met by either introduction or on social media, to start new projects. So, as much as I miss getting into my Qantas jammers and chatting to people from all over the country as we get in the plane, and it's a little treat to do that, and then working in your butt off for a week trying to get some new studies across to Australia, we've got new ways of doing it. So I'm excited that we've learned those, and we've learned new ways of reaching out and finding new ways of working together nationally and internationally.
Yeah, fantastic. Yeah, I'm a big fan of Qantas pajamas. I wear them every night I get home from work. And if the sun's down, so in winter it's socially acceptable to put your pajamas on when you get home, right? And so I'll go the Qantas pajamas. And yeah, I miss that whole face-to-face interaction as well. But who knows whether we'll be there next year or not. Let's hope so. So fantastic discussion. Thank you so much. Great to get your insights into these abstracts. We put the links to the abstracts on the webpage so people can open them up and have a look at some more detail. Thanks for taking some time out and your busy schedules to come on the podcast.
Absolute pleasure.
Thank you for having me.
You've been listening to the Oncology Podcast. If you enjoyed today's edition and would like to subscribe, head over to our website, oncologynews.com.au, and sign up to our newsletter. Thanks for listening.